last but not least for our speakers today is Julia Bloomfield. And again, we're just moving down this gradient here from global to national to, I guess, subnational, we call it technically, but more at a local level in that the view of implementation. So Julia Bloomfield is a registered adult nurse who has worked in critical care nursing and also has her diploma in infection prevention and control from Oxford Brookes University. Following a varied nursing career in gynecology and ICU, Julia became an IPC professional in 2004. She has experience in primary, community, and secondary care, including independent healthcare providers. She has been leading primary care IPC services at the National Health Services in Somerset Integrated Care System. This was formerly the Clinical Commissioning Group since 2019, strategically supporting 64 primary care healthcare providers. Julia has developed primary care specific quality improvement toolkits, audit tools, and resources to support infection prevention and control leads within the region of Somerset. So Julia, over to you.
Thank you very much for this opportunity. I look forward to sharing what our infection prevention and control programme looks like in the county of Somerset in the southwest of England. So I will share my screen and hopefully you'll be able to see my presentation.
We can see your slides, and I will just say maybe if you can maybe speak more closely to the camera, the microphone, or a little bit louder, just a little bit quiet on our end, I think, but good to go.
Thank you. I can't quite see my presentation, so I will look at my other screen. So I will be talking today about infection prevention and control in primary care. And as you can see, it's a picture of Glastonbury Tour in Somerset. And that is the scene that we get from Glastonbury Music Festival each year. So throughout the presentation, we are going to show a couple of pictures of other localities in Somerset. So the main session outline today is going to be talking about what NHS Somerset is and who we are. We're going to be talking about the challenges that we experienced in primary care from an IPC point of view, and talk about the solutions required and what our current infection prevention and control programme looks like in primary care in 2022. We've got lots of positive outcomes from the work that we've undertaken in the last 3 years in particular. But also we've experienced some difficulties through a very challenging 3 years. And we had some lessons that we learnt as a result of the IPC training and education that we put in. So who are we? NHS Somerset is an integrated care system, and as part of that system we have an ICB, which is an integrated care board. We have been very lucky to have our own infection control team. Just from a national perspective, each hospital has their own infection control teams. Regionally at NHS England, they have national and regional infection control teams that support each district, county, but also each ICB, which is a commissioning service, also has either an infection prevention and control specialist or a team that works independently from quality services at that organisation. So we are very lucky to have a group of us. We support 220 nursing and residential care homes across Somerset and 64 practices, which are healthcare centres. And we also quality monitor our 2 acute hospital trusts. We also work very closely with public health services and our UK Health Security Agency. So this is Wells Cathedral, and an element of history coming through there. We're right down at the bottom of the southwest of England, and we're located amongst others. So we border Devon and Dorset. We also border North Somerset and Bath, and in the northeast of Somerset. They all have their own integrated care systems, and so we just look after a population in Somerset of just over 500,000. We're a rural county with one major city, which is Wells. When I say major, it's not major, it is actual fact the smallest city in England. But our largest urban areas are Taunton, Yeovil and Bridgewater. We have population difficulties. In fact, the west of Somerset is known to have the highest population of elderly, that is people over the age of 65, and that's across the UK. So we have a very elderly population in our population in Somerset. So our GP services are made up of 13 primary care networks, and the GP practices are grouped together within those PCNs. We have a distinct traveller community, and in 2020 we had 539 traveller caravans counted. That information is from Somerset County Council. And as I've already indicated, Somerset has the highest population of people over the age of 65 in West Somerset. 48% of the population live in a rural area, and we have a situation where from one end of the county to the others, it could take a travelling time of over 2 hours. So we are quite a large county. So back in 2019, the existing clinical commissioning group, CCG as it was known back then, had some infection prevention and control challenges that they were facing. And at the time, they recognised that there was no strategic primary care IPC lead in place. They recognised that there was a minimal programme in place with limited infection prevention and control quality assurance monitoring. Somerset GP practices were not fully engaged with IPC quality improvement projects, and that was probably due to the limited engagement with GP practices. At that time, we had one infection prevention and control nurse who was undertaking community as well as healthcare associated surveillance. She was supporting the 220 care homes, quality monitoring the 2 acute trusts, and also trying to support the 65 GP practices back then. Plus, the other situation was that the national IPC guidance was often hospital-based and focused, and therefore the focus in primary care for IPC was suboptimal. And as you can see there, we have EPIC 3, who was our national evidence-based guidelines, which was heavily focused towards hospitals in England. So what were the solutions? It was collaborative working. We needed to gain the support of our local Somerset local medical committee, which were the GP practice representative organisation. We needed to work collaboratively and jointly with our commissioning and contract colleagues. We needed to network with NHS England and our regional IPC colleagues in the Southwest. To avoid reinventing the wheel, we had to ensure we were working together and working collaboratively. We needed to implement an IPC programme, which included a link practitioner support network, and we needed desperately to build relationships with GP practices and their IPC leads. We also needed to highlight the national policies and the national IPC guidelines. And the main focus that we wanted to undertake was to introduce and enhance their knowledge of the Health and Social Care Act of 2008, which was our code of practice on the prevention and control of infections and related guidance from our Department of Health. So we started in 2019 by employing myself. We ensured that we had an IPC specialist nurse at primary care level within our district. We ensured that we had an IPC lead at each of our 64 GP practices. We commenced monthly linked practitioner educational support meetings, and we then discovered that the IPC leads themselves were not sure what was required of them. So we designed a roles and responsibilities job description, and that was instrumental at starting the ball rolling to ensuring their sign up and engagement. We quickly realised that the infection control leads were not quite sure what to report, so we designed an annual template so that they could give an annual report of what work they were undertaking on an annual basis. So the first thing we did was to develop some guidelines which were primary care adapted, because we needed to get on board with GP practices that infection prevention and control was absolutely aimed at them and not just hospitals. So we developed the Somerset Primary Care IPC Good Practice Guide. It contained IPC procedures aimed at GP practices, and it also had information to other links, and the links were to other national guidelines. So for instance, under hand hygiene, we had links to videos, we had links to the World Health Organization posters for the 5 moments of hand hygiene. We also became very aware that the national audit tools were not applicable to primary care. So we adapted them. We adapted infection prevention and control audit tools, cleaning, PPE, and we also asked them what they needed. That was how we got the engagement. We asked them what did they need help and support with. National policies and guidelines were presented, summarised, introduced, as a lot of the time, primary care IPC leads are not standalone infection prevention and control nurses. They have clinic times and they are often champions of other areas within healthcare. So it was very much summarising the guidance for them and introducing to make it understandable for them. We also adapted the NHS Infection Prevention and Control Board Assurance Framework, which was a quality improvement tool. And we also informed primary care about the NHS Infection Prevention and Control Manual for England, which was introduced in 2021, as well as the National Cleaning Standards, which was also published in 2021. So the programme that we wanted to implement was introduced, and looking back, since it is very largely based on the World Health Organization core components. So we introduced education and training. We, as I've already indicated, have monthly network meetings, but we also introduced quarterly infection prevention and control training for all practice staff, not just the IPC leads. We wanted to make sure that healthcare colleagues from GP partners right down to the cleaners had access to infection and prevention and control training and education. We provided support on site visits, and in the middle of lockdown and in the middle of a difficult pandemic, we recognised that on-site visits were not always indicated. So therefore, we started one-to-one virtual support meetings via Teams or Zoom. We in England have always had a very heavy healthcare associated infection surveillance system, and primary care was also part of that. So we introduced and enhanced our surveillance system. We had post-infection reviews for MRSA cases and Clostridium difficile cases that were considered to be community onset. We also undertook some outbreak management, risk assessments and training and education, and we also did some deep dive work around E. coli bloodstream infections. Part of our multimodal strategies were to enhance environmental cleaning standards and cleaning audit tools. We wanted to support with clinical waste management, and the ICB is instrumental in that because they hold the contract for clinical waste management across the county. Cold chain support to prevent vaccine storage incidents were part of the IPC programme, and also we supported in immunisation and vaccination centres which were being introduced as part of the COVID immunisation programme. So we were actively going out to those buildings and ensuring that the building and the IPC procedures were in place for the vaccination centres. Built environment, materials and equipment, we ensured that we had an IPC annual audit to assess IPC procedures, the buildings, facilities, equipment and environmental and decontamination. As part of the core component of monitoring and feedback, we ensured that we were part of the assurance framework meetings, and that was reintroduced in 2022. They are there to monitor, quality monitor, and to ensure that the contractual arrangements are in place. We undertook vasectomy service assurance visits and dermatology service accreditation visits. And as part of our workload core component, we ensured that triage was being undertaken before the patient even hit the building. So triage was being undertaken to ensure that isolation facilities were put in place if they were required, particularly for patients undertaking visits where there was respiratory issues at play. Part of our contract arrangements and joint working with the ICB and LMC colleagues, we ensured that specific IPC arrangements were introduced in our local GP contract. So annual IPC audit requirements and mandatory cleaning standards now form part of the local GP contract. Collaborative working with our LMC nurse advisor was absolutely key. So the LMC is the local medical committee. They are the GP representatives, and they are an influence figure amongst GP practices. So to get their sign up and their engagement was absolutely key in our success in our infection control programme. We worked extensively with our quality leads who undertake quality improvement training and designed COVID-19 outbreak risk assessments. And also finally, we were invited to monthly strategic primary care operational group meetings where we could share intelligence about practices and healthcare centres and if there was issues around poor performing services. So as I've already indicated, how did we get the sign up? How did we get engagement? Because that was the key thing that was missing back in 2019. And collaboration is absolutely the main takeaway. So post-infection review was undertaken with GPs, which showed that community-associated MRSA bloodstream infections was caused after a joint infection in primary care where skin decontamination was not performed. We were able to inform GPs that IPC was a patient safety issue, which enabled sign-up. We also were able to show that antibiotic prescribing was an issue in treating C. difficile in the community. What we actually discovered was that some of the antibiotics were not available in our pharmacies. We also found out that metronidazole was being prescribed where it was no longer the first line drug after it was being updated in NICE guidelines, and vancomycin was now the first line drug treatment. So we were able to give an update to GPs, and they then quickly came on board, that they saw our support as invaluable, which we were updating their knowledge. Sign up was achieved by working collaboratively with primary care quality colleagues. Primary care became engaged because we adapted IPC policy. They no longer said, well, it's not applicable to us because that's all just about hospitals. We were able to show that the work we were undertaking was improving infection prevention control, and it was absolutely key in primary care facilities. We were able to work collaboratively with quality leads and contract managers who in turn could see the helpfulness of the service that we were providing, and so therefore started to share intelligence with us. And when quality leads identified that some practices had little IPC governance or an audit programme, and in fact they were also able to share with us that IPC colleagues were asking for support when they went and undertook their own visits. We commenced joint visits with practices who were underperforming or had care quality commission inspections, and those practices where they had areas of concern, we were able to go in and support and undertake improvement projects. Quality leads asked us to become involved in dermatology services accreditation visits, and practices found these visits really helpful and supportive, and we promoted international primary care minor surgery guidelines that GPs and IPC leads were not aware of at that given time. We identified minor surgery as in primary care as a quality improvement project, and therefore we visited 5 healthcare centres where they were undertaking a vasectomy service. We enhanced skin decontamination procedures, building compliance. We improved the usage of PPE and hand hygiene procedures. So the positive outcomes of our work were mainly we increased and built relationships with colleagues across Somerset. In particular, IPC leads felt valued and supported, and they didn't feel patronised. They felt that if they had questions and needed support, they had somebody to go to. The quality improvements that we made were not only just in minor surgery and dermatology and vaccination and immunisation, but also we made great strides in increasing our cleaning standards in GP practices. We also promoted infection prevention and control, such as ventilation, isolation, and outbreak management, and also wearing appropriate PPE, particularly at a time of the pandemic. IPC lead clinical governance improved substantially. We made advances in our audit programs. We improved in patient safety activities and health and safety for staff, and we improved buildings and estate compliance. We have now been able to introduce a board assurance framework using a PDSA cycle in 5 GP practices. This was introduced by the NHS, and it is an example of a checklist of a way to give assurance to GP partners in healthcare centres of that they're making sure that they're doing everything in accordance to the code of practice and the 10 domains that is within the code of practice from the Department of Health. We were able to undertake work plans and annual reports, so to ensure that all GP practices have the documentation required as part of their IPC clinical governance, and the care quality mission inspections were much improved. We no longer have a situation where infection prevention and control is seen as an area of concern when GP practices are inspected. The difficulties we have experienced: the pandemic, the workload capacity for all primary care colleagues. We have experienced high staff turnover. It has only just been recognised that from July 2019 to July 2022, we have seen 35 million extra appointments being required in GP practices across England. We've faced GP IPC leads not having any time to focus on infection prevention and control, little ring fence time for IPC quality improvements. We still understand that IPC importance is not fully acknowledged by senior GP practice staff. We've got a situation where IPC leads are not given the authority to make change, and we still have a situation where budget is tight and finite resources for estate improvement. I think the major difficulty we've had in the last 3 years is that IPC leads have felt completely overwhelmed with the amount of national policies that have been introduced, and also the COVID guidance coming out in a substantial way. So our lessons learned: carrying out on-site visits for practices who don't engage and attend, and those who don't attend lead nurse meetings. What we wanted to really find was, even though we introduced quarterly education and training sessions and monthly education for IPC leads, we still had practices who weren't engaging with us. We would communicate with them via email, telephone calls, but we still weren't getting that monthly engagement. So I think probably we should have undertaken a phone call to say, we will come out and see you. And I think that would have helped with the engagement. We needed to ensure we had concise information. At a time when we had a pandemic, we had guidance coming out sometimes on a weekly basis for COVID. So we needed to make sure that the information we were giving was concise and make it not so overwhelming. We also needed to make sure that we disseminated information to practice managers and senior GP partners. We also needed to engage a lot more with the executive directors of the local medical committee. So our lessons learned really are to ensure that we have a top board to a board level approach. Develop joint visits with the ICB quality improvement leads and the LMC nurse advisor. Although we have undertaken joint visits, I think we've all felt that probably going forward we need to do more of that. The other thing that we have learned is that during the pandemic, we stopped our quality assurance visits just purely because of the workload. But in effect, we probably needed to keep them going, even if we had have done them virtually. It may have just ensured that that engagement was continuing. Finally, the IPC Good Practice Guide was written pre-pandemic and before the National IPC Manual for England was published. So we've now come to a situation where our IPC guide is no longer required because we've been able to influence our national colleagues. Prior to the pandemic, there was no primary care elements within national documents. So what we've been able to do is influence our national colleagues to say, please ensure that you have some sections which are primary care related, which is what they've done. So therefore, our IPC Good Practice Guide will be adapted. It will now be undertaken to include audit tools, job descriptions, annual reports, templates, and where to find more information. So the links to information rather than the IPC procedures itself. Primary care has adapted because of the pandemic. However, apathy has set in. So our work will continue. And that's where quality improvement will always take place. And there's some references. Thank you very much.
Thank you so much, Julia, for the for the example of great work that's been done in Somerset. I mean, that was no small mountain to climb, to having to start from scratch. And I think, again, it's nice that we've been able to sort of go from global to local. And it's a nice translation of what I think Mandy started setting the scene of. Here's some data, here's what we got. And what are the standards we have at global level, to how that trickles down into actual countries and implementation. So thank you again to all our speakers so far, Mandy Deves, Apollo Bassanero, and Julia Bloomfield. We still have a few minutes here, and I think given that we can't all be live with our audience today, it might be nice to have a little bit of question and answer period between ourselves. But I think, for myself sitting on the outside listening to all of you today, I know that often in these kinds of presentations, it's always nice to get the opportunity to ask the speakers, what is the number one key takeaway from yourselves with respect to everything that you've talked about today? What is it that you really want participants to leave with that, looking back on the last few years of work that we've all been doing, what are those nuggets, or what is that nugget that you want to impart today, that when people leave here, they feel a bit empowered on how they can approach their implementation with respect to strengthening infection prevention and control, quality of care at the primary care level? So we'll let Julia take a quick breather, since she did just present. Maybe we'll start at the top with Mandy, work our way down to Apollo, and then back to you, Julia, if that's okay. So Mandy, first up.
Okay, so I think what we're hearing from colleagues and who are working in or supporting primary healthcare is that there's interest in continuing to support implementation at the country or the facility level. So whether that's through resources or other implementation supports. So you remember I mentioned about a survey that was done looking at the implementation of the infection prevention and control assessment framework in primary care. And I think next steps would be, with the goal of this work, looking at next steps would be to describe the burden of HAI in primary healthcare, and that can sort of help and support that buy-in for why you need to prioritize implementation of infection control among the many other priorities that sort of compete for attention. And then related to implementation, having that minimum requirements tool to help provide that assessment of the status of where you're at with implementation of your infection prevention and control program. And something I didn't highlight in our slides was that on our core components webpage, there is access to that assessment framework, as well as a global IPC portal where you can access all the resources that you need to do that measurement of implementation. And then finally, we reviewed the toolkit of education resources that we have available. We're also doing a community of practice, which offers a space to connect and network with others who are also supporting infection prevention and control. So you can go to our website and just do a Google search for infection prevention and control global community of practice and check that out. And I think from Julia's last slide, one of the things that jumped out at me is that COVID has taught us a lot about working virtually so that we can continue our work during the pandemic. And I think this platform platform offers the opportunity to further explore how we can do that supportive implementation virtually. So I'll pass it over to Apollo next.
Okay, thank you so much, Mandy. I think for me, really, one take-home message here is that integration is key, especially when we have limited resources. We can't really afford to work in silos. We need to integrate IPC activities with all the other close activities like other quality improvement initiatives. And this integration can be looked at different levels, at national level, at the sub-national levels. For example, at national level, when we are looking at planning and budgeting, we really need to find how we can integrate these different activities. For example, conducting support, supervisory visits also, they should be combined. For example, the quality team and the IPC team going together to do these support visits. Also, training. If we are looking at training of healthcare workers, again, this is a good area where we can integrate the quality improvement initiatives and also IPC. And then, of course, at subnational level, again, there are opportunities of integration. For example, in each of the departments or service elements, IPC should be part and parcel of the activities that they are doing. But also things to do with like meetings at the facility level. If you have, for example, therapeutic meetings, quality improvement meetings, and then IPC meetings, and most of the time it's the same people that come for these meetings. So again, there's an opportunity there to integrate. But I think one caution perhaps as we integrate is to make sure that the importance of each of these elements is emphasized. For example, in quality activities, other quality activities shouldn't overshadow IPC component. So as we look at this component of integration, again, it's important to emphasize that each of these activities for IPC, they are really important and they shouldn't be overshadowed by other activities. Yeah. Thank you again for the opportunity. That's what I wanted to share. Thank you.
And over to you, Julia.
I think my takeaway moment is collaboration, and more collaboration. We absolutely would not have got one step further without collaboration of all colleagues that work within primary care. So we could not have done this in silo. We needed the support of our influencers. So it was working with GPs themselves. It was working with nurse advisors. It was working with quality improvement leads. It was working with contract managers. It was working with everybody together to make a program successful. But also to get their engagement, it was to prove that infection prevention and control was pertinent in primary care. Our guidelines were very specific around hospitals. And we needed to prove that infection prevention and control was absolutely key in primary care healthcare facilities, because GPs didn't believe that infection prevention and control was an issue. So it was having the surveillance, and the surveillance was undertaken from a post-infection review or root cause analysis. And we were able to show the root cause of what our MRSA bloodstream infections were. We were able to show how we can improve the patient outcomes after a C. diff infection, and not how to necessarily prevent a C. diff infection, but it was looking at the effects of antibiotics and antibiotic prescribing. Antibiotic stewardship within primary care is just as important, if not more important, than what's going on in a hospital setting. So it was engaging them by adapting initially the national guidance to primary care, which made them sit up and listen. And then once we had their engagement, they were then saying, but hang on a minute, what you're telling us to do in Somerset, what about the national guidance? It introduced the national guidance to them. And so now we're at a situation where our national colleagues are introducing primary care in our national guidelines and policies. And so that our job is done in terms of bringing in guidelines from a primary care perspective. But what our job now entails is the core components and continuing that work.
Well, thank you so much, the three of you. I mean, I think that's a perfect summary of today. You know, you've got the advocacy, what are the standards, how do we help build that case for IPC and primary care global? You've got the integration moment with quality, and that no aspect is above one another, and we're all here for safe care. And then, you know, Julia, just now, the collaboration and making anything happen, you have to work together. I mean, and that is the beauty of IPC, is we do get to do that. And so let's make safer care by strengthening IPC in primary care. So with that said, I just want to say thank you to all our speakers today, Mandy, Apollo, and Julia. Thank you to the audience, and thank you, Shams, for the support in today's session. That's it from all of us today. Have a great day, everyone.
Great. Thank you all for making the time, and thank you to the IPC team. Just one quick point is that if anybody needs to connect with the technical IPC team at WHO, please just let myself or my colleague Irina know, and we will make sure that you have direct contact with the technical colleagues at WHO. So please feel free to just jump and give us your contact details, and we will pass that on. Have a great lunch.